Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and a leader at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of February 15th. It is exciting times as always. Globally, there are almost 110 million cases of COVID-19 with 2.4 million deaths. That's worldwide. In the United States, we are at almost 28 million total cases and over 488,000 deaths. This is as of the day I'm recording this, February 17th. In kids, and this is from the AAP report dated February 11th, we have over 3 million cases of COVID-19 in pediatric age patients, accounting for 13% of the total. This comes out to just a little over 4,000 cases per 100,000 population in pediatrics. Arizona, well, we're not number one anymore, but we are number 5 in terms of our attack rate. Cumulative, we have 125,281 cases, or 15.9% of the total numbers of cases, comparing that nationally to the 13% I just mentioned. Our average per 100,000 comes out to 6,814, putting us in the top 5 of the country. We are number 1 in the country for number of children hospitalized at 1,511. The closest second is New York City with 1,129 after their outbreaks. We are currently showing 22 deaths related to COVID-19 in Arizona. That puts us at the number 3 position nationally. Texas is number 1 at 39. New York City is number 2 at 23. So I share these numbers in no way to say, yay, Arizona, in fact, quite the opposite, and simply just to affirm what everybody here knows, and that is that we have seen a ton of COVID-19 and will see a ton of COVID-19 related complications and disease ongoing. Hopefully those numbers are about to plateau and perhaps even decrease, as we are seeing in terms of the adult and the total numbers, both nationally and also in Arizona. But as we all know, there is the threat of the mutant variants coming out, and it is hard to predict what impact those are going to have. Let's start the first round of questions, and again, some excellent questions this week. First round has a lot to do with our vaccine outreach and vaccine programs, and the first has to do with something I think many of us have seen, and that is that members of the general public have been, it's been suggested for them to apply to volunteer at the various vaccine delivery sites in hopes of getting a vaccine. And the current requirements are that an individual work 36 hours, that's to discourage the casual volunteer, show up, get their shot, and leave. And I would say, just anecdotally, in talking to people who've done this program, it has worked for those who are able to get the hours. Unfortunately, and perhaps this is a fortunate thing, which feels unfortunate, all of the volunteer time slots are filled up. So there have been individuals who have been able to work 2 shifts or maybe 15, 16 hours or so, want to volunteer more time to be in the line to get their vaccine, and are unable to because everyone else is doing the same thing. I'm asked, in the question about my opinion about this program, and I guess I'm of several minds. On the one hand, it absolutely is a great way to get free help, volunteer help, to help staff the vaccine clinics, which are critically important and which potentially would suffer from understaffing. On the other hand, I think, unfortunately, it offers some false hope, and there may be a fair number of people who may get their first injection without clear preparations made to get them their second. Although, as we all know, getting a foot in the door with shot number 1 is a great way to prepare and hopefully get a guarantee of shot number 2. So, it's a great program. I think we'll just say that. I think its intent is fantastic. The reality and the logistics are that it's very difficult to get the hours necessary to actually be given not the free, but to be given vaccine prior to one otherwise qualifying for vaccine versus the priority. This, of course, is not as big a concern for those of us who are active healthcare providers and patient facing. We should have already been offered vaccine, should have being the key word there, as being priority 1As. However, even then, the rollout has been somewhat haphazard. Another part of this questioner's question is asking me to comment on Governor Ducey's advisory, which also came out recently, in which he said, it's all hands on deck to get vaccine delivery, and we need to now get buy-in from the federal government. I think this is a suggestion that our vaccine program, our vaccine delivery sites, are now finally up and running and as smoothly as possible, and we're now being held up only by lack of delivery of vaccine doses from the CDC and the federal government's stockpile. I'm not even sure there is a stockpile, quite honestly. That was a promise by the former administration. What's actually happening is as many doses as can be synthesized and made by Pfizer, by Moderna, have been pre-purchased and are being delivered and rolled out as quickly as possible. The challenge is, and I think all of us have seen this in the media, the challenge is that vaccine delivery is now being keyed in a prioritized fashion to those states that were most successful in getting vaccine delivery into their state citizens' arms. Unfortunately, Arizona, not so very long ago, i.e. last week, was the 50th worst state in getting vaccine delivery into its citizens. And there's no finger pointing here at all. It's just that the horribly challenging logistics, and also following the initial federal government's suggestion, which was to empower local authorities to do the vaccine delivery. So feds empowered the states empowered the counties. The counties, and my county, Pima County, is a pretty well supported county, but of course there's never enough resources and never enough funding. And even then, we had significant challenges in getting any more than 2 hospitals to step up to be the initial vaccine delivery sites. Now, finally, at least in my town, in Tucson, we're now finally getting a state-supported vaccine delivery site 5 months after vaccines were potentially available. Well, that's a bit generous, 3 months even. But even so, there's been a significant catch-up, which unfortunately has negatively affected our vaccine delivery, and even the vaccine registration sites have been many, and they don't crosstalk. So it is not surprising if any of us, and I include myself in this, have faced questions and or family members and or friends of friends who are frustrated to the point of tears at the inability to get vaccine. I completely empathize and sympathize with all of those. This has been an unqualified mess. And I say that very strongly, and again, without having any easy solutions other than to step up, get clear communications, get the vaccines, and have somebody leading the show. And that somebody, I think, needs to come from more than just local county authorities. So there you go. That's opinion, not fact, other than the fact that Arizona was the 50th worst state. We're all the way up to 47th worst in the country right now. So we're moving up. Fantastic. Hopefully things will change as we get more state-directed vaccine delivery sites. The 24/7 sites have been very successful. The staffing appears to have been adequate. Now we're being held up only by vaccine delivery from the federal government. Alrighty. Next question then has to do with the Pfizer vaccine, and that this is somewhat related. And the questioner says that the Pfizer vaccine recently showed a 92% effectiveness after 1 shot. Do people really need to get a second injection, or would it be better to get more people immunized with just 1 shot? This is a fabulous question in terms of the strategic outreach and strategic approach to the logistics of getting as many people vaccinated as possible. The first thing is to be clear, the Pfizer vaccine of 92% effectiveness was a very tiny subset of a very low-risk patient population. And in fact, the average numbers, if we include all comers, and here I'm talking older age people, those with immunodeficiencies, etc., the average is much more close to 60%. So while that's above the initial 50% cutoff that the FDA was looking for, and that's certainly quite good, it is not the 92%, which would be really quite wonderful and reasonable. So That alone would suggest that not just delaying, but not giving a second injection is not ultimately a feasible option to protect the protection administered by the vaccine outreach. However, there is wiggle room. So the initial 3 week between the two injections for Pfizer and 4 weeks for the Moderna vaccine can be extended, and there actually has been mathematical modeling looking at the ability to extend each of those time frames by varying numbers of weeks, which would mean that the initial vaccine recipient, the first injection, provides partial and adequate protection. Can that be enough to mitigate severe disease and or acquiring even mild to moderate disease sufficiently to allow other people to receive their first injection? And if so, can we increase the total vaccine coverage and start to create herd immunity more quickly than if everyone gets their vaccine in the normal timing? The mathematical modeling suggests that is so. In fact, one model suggests that delaying even 2 weeks for either injection could increase by 30% the total vaccine coverage of this country, all comers. That's exciting. That's definitely possible. And I suspect, just hearing the language coming out of the CDC and certainly by Dr. Fauci, that is an option which can be considered. However, the current official recommendation remains 2 doses spaced by the properly planned time, because that is what the phase 3 studies performed, and that is what the known efficacy of 95 and 94% Pfizer Moderna comes from. So I think stay tuned. Perhaps even over the next several weeks, we may see more both data as well as official recommendations to play with the spacing somewhat and try and get more first-time vaccine recipients vaccinated and then take it from there. Next part then has to do specifically, of course, with our patient population, and that is vaccine testing, vaccine plans for the pediatric population. As of right now, Pfizer and Moderna are attempting to recruit teens or tweens from 12 years of age and up into the studies. That vaccine recruitment has been very slow. The hope was to get 3,000 12-year-olds and up enrolled into both studies independently per week, and in fact it's been much more like per month. No information on what the holdup is. It certainly can be a combination of vaccine questions, those who are just not prepared to enroll their adolescents, their children, and or it could just be that the number of vaccine sites actually doing the recruitment are no longer as active and no longer as prevalent. The question sent to us, however, is specifically about AstraZeneca, that is now testing on ages 6 and up. And the questioner basically asks, what's up with the others? Why are they not testing down to age 6? And clearly that is a population that we would like to test and get safety and efficacy data on and start to immunize in preparation of school openings going forward. Absolutely agree with that. I have no information and not even any guesses about why the other 2 manufacturers have not started to enroll. It may be an issue of logistics, of money, of timing, who knows. But it's interesting that of the 4 potential vaccines that this country could be using right now, the 2 we currently are, Pfizer, Moderna, the next one, Johnson & Johnson or Janssen Pharmaceutical, which has gone to the FDA as of now a week and a half ago. We can anticipate approval coming up soon. And then AstraZeneca is the one which has not gone yet to the FDA for emergency use authorization of its product in adults. And yet that's the one that is robustly doing safety testing in all comers from age 6 and up. So I suspect that we will first see benefit in the pediatric population tested and validated in the United Kingdom and in Europe, where that vaccine is already in common distribution. I can only hope, as the rest of us, that the active vaccine products here in the States will follow suit quite quickly. Certainly that rollout has been proposed by Dr. Fauci with an intent to test safety and efficacy in all currently approved vaccine products, in ever decreasing age ranges, with an attempt to get all school children access to vaccine safely by the start of next school year. So we're talking next August. Of course, to do that, you got to start someplace. And if the initial enrollment in this country of 12 years old and up is any indication, we've got a long ways to go for that to happen. So again, no clear answers, only a little background, a little backstory, and a hope that as we go forward, that we as pediatric providers in the state of Arizona may be given license to help recruit. That would be fantastic. And just as we have shared decision-making conversations with, for example, our adolescents for the meninge type B vaccine, or even for the HPV vaccinations, so too could we potentially have those same conversations, safety, efficacy, societal benefit, etc., with our younger patients to get them COVID vaccinated. Vaccinated. So fingers crossed that actually comes true. Alrighty, so a question then goes into the mutant variants. And do we know how much of the current mutant variants, i.e. the ones from the United Kingdom, South Africa, and also Brazil, how much of those are circulating in our community? We know only what we know, which sounds kind of dumb, but that's an indication that to actually know what the types of circulating virus are circulating in the community, we need to do a genotyping of those viruses, and there are only a few virology labs in the state that are currently doing that. This has been a problem countrywide. So unlike many parts of Europe and actually South America and the continent of Africa, the States, this fabulous first world country with awesome science resources, has been caught with its pants down, quite honestly. Pardon the euphemism. So we are just now starting to tool up and funding and empowering our excellent scientific researchers to do the genotyping, to find out where the variants are, and to give some epidemiologic predictions of what and when we may encounter higher infectivity and higher contagiousness of these variants. So that is a soapbox answer, to the question, which is very appropriate. We don't really know. What we do know on limited data is that indeed the B117, that's the United Kingdom mutant variant, has been found in a certain number of people in the States, in Arizona, and so too a recently described mutant variant from California. Those are the two most common, and that's a relative term, mutant variants so far identified in Arizona by the few wonderful individuals who are doing that testing. It is expected, certainly by me and certainly by the scientific community, that we will soon see the South African variant and we will soon see the Brazilian variant, and those absolutely have increased infectivity, anywhere from 30 to 50 to even 70% more infectious than the current standard strain, which, as I mentioned before, is itself a mutant variant, the D614G variant. So what does that mean in terms of risk to and from children? That's the big question. That is why this is a not only hot topic, but critical question in terms of our patient population and the risk of school reentry. If the South African variant, which of the ones so far described is the most infectious, that's the one anywhere from 50 to 70% more effective, and also 30 to 50% less covered by vaccines and the current monoclonal antibody cocktails which we're using, if that variant were to gain a toehold in Arizona, and certainly elsewhere in the country, it would rapidly take over the circulating strain, and it would change the game completely, to the point where our current kindergarten through 5th grade or 6th grade students, who in the COVID-19 pandemic so far have not been the super spreaders that we expect with a typical influenza pandemic, that would change. And the expectation is that our young children would then become the same super spreaders that we expect every year with the flu, with rhinovirus, and with RSV. And so to open in-person school with high community numbers, with children now able to acquire that infection at school and bring it home and infect their parents, their families, their grandparents, etc., that would be cause for grave concern. And certainly our numbers would continue to escalate. I'd leave the rest of your imagination. So all of that is a definite possibility. That is absolutely my concern. How do we avoid that? By getting as much reduction of viral burden of the SARS coronavirus 2 globally and locally as is possible and quickly as possible. Certainly, nature has not stopped. She's not sitting back in her armchair sipping her whatever you want to sip at night. She continues yeah, this is just nature, to empower viral mutations such as occurs with the flu every year. That's the concept of antigenic drift. And heavens forbid we have a more robust genetic mutant, such as we see with antigenic shifting. So that continues. And the longer that there is active virus replicating in people's bodies, especially our long term replicators, those who are immunodeficient, those who are cancer survivors, patients who have active virus in their bodies for more than just the couple days or weeks that we expect, and instead weeks to months. Those are the individuals which have been the site of the emergence of these mutant variants. So until we can control that global viral load to the point of being sporadic at best, then there will continue to be mutant variants. And we will, I guarantee this, we will see established a mutant variant which is resistant to the impact of the vaccines currently available. This is guaranteed unless we can act quickly. Hence, my personal frustration, and I suspect those of all of you as well, with the inability to get our act together and to get vaccines into people's arms. Not just getting them delivered from the feds, but actually having effective vaccine sites. It needs to happen yesterday. And until that happens, I think we can anticipate significant concerns in terms of our bioepidemiology for the pediatric population going forward. However, I guess the good news is that is not the story right now, today, February 17th at 7:53 a.m. as I record this. With any luck, things will change soon, and we can hopefully avoid that. And as of right now, the current vaccines, which are licensed and being administered in the United States, remain effective against all variants that we know of. They continue to be minimum of 60% effective at preventing mild to moderate disease and 100% effective at preventing severe disease. So this is absolutely the time to get those vaccines delivered quickly. Alrighty, next question. We're going to sort of move away from vaccines and mutants into more clinical. And I think many of us, or at least some of us, may have seen a recent article published in Journal of the AMA, in JAMA, that examined the impact of vitamin C and zinc and a couple other supportive regimens on the effect of COVID. If you recall, there had been a hope, or at least an observation, that those individuals who were vitamin C deficient had worse outcomes with COVID-19 or were more severely infected. And that hope, or that observation, I should say, was sort of turned around into a preventative regimen. So, like, hey, if you want to avoid, getting severe COVID-19 until your vaccine kicks in, load up on vitamin C, load up on zinc, everything else that we do with our current approaches to upper respiratory viral infections. Unfortunately, this carefully controlled and well-conducted study just published found no benefit from those interventions in preventing disease, period, or preventing severe disease, unfortunately. Why might that be? Well, again, I think we have to look back at the initial indication for using these products, which was based on very bad science. It was an observational study, incredible selection bias, and only those individuals who were already inclined to take those supplements, who themselves may have had different risk of severe disease or acquired disease, those are the ones who were studied. So I think it would be not scientifically appropriate to have the preset expectation that high loads of vitamin C and zinc do anything to prevent acquiring a viral respiratory illness. Instead, we can think of them as indicators of an individual's general nutritional health. Healthy individuals nutritionally have healthy immune systems and in general, selection bias, tend to make healthier choices. They may not be the ones who go and unmask in a gym or suck face in a movie theater. So it may well be that we're now finally seeing in a well-controlled setting the failure of impact of those interventions. So as of right now, in case any of us were recommending use of vitamin C and zinc, I think I would alter that recommendation to healthy nutritional choices. Get those leafy green vegetables, have the citrus fruits. All those are fabulous things. And in addition, make other healthy choices as well, including physical exercise, mental health, and especially during the COVID-19 pandemic, where our pediatric patients are suffering, and they're suffering hard. mental health disorders, depression, anxiety, suicidality, intentional and unintentional drug overdoses. All of these things are occurring every single minute of every single day right now here in our practices. So we've got a lot of work ahead of us, specifically related to the pandemic, which makes already a challenge in pediatrics that much worse. So I think there you go. Once again, I appear to be on a soapbox this episode, so I apologize for all those. This is just trying to tell it like it is. Last question, then, getting much more into the clinical aspects. Children who survive the multisystem inflammatory syndrome in children, the MISCI illness, how often do we follow these children? And how are these kids doing? What is their prognosis? Are they even surviving? Yes, thankfully they are surviving. We certainly, at least I have, and I think many of us have seen locally, an uptick in patients presenting with suspect or confirmed MISCI. In fact, last week I had 3 hospitalized at the same time. Overall, these patients, if they are identified and treated in a relatively timely fashion, they're doing well. Many of them, in fact, are developing or during admission, demonstrating evidence of myocarditis, of decreased systolic and diastolic cardiac function. Some are developing dysrhythmias. Most of our patients now, per protocol, and the protocol as established is for the American College of Rheumatology, and it's a good one. Most of our patients are being treated both with intravenous immunoglobulin and with methylprednisolone, with steroids, followed by a steroid taper. And on that regimen, they are recuperating. If they require pressors upon admission, they're weaning off the pressors, and they're discharging home on their oral low-dose aspirin and their oral steroid taper, and they are being followed up, and appropriately so, by pediatric cardiology and also through those of us in primary care and or infectious diseases. So, yeah, they need all of those things, and they are demonstrating cardiac involvement, but thankfully they're recovering. For those students who are student athletes, this is a cause for major concern because their exercise tolerance is decreasing rapidly, even in hospital. They not alone, but they experience deconditioning quite rapidly. And so a return to sports is going to be a very cautious, guarded affair, and it needs to be guided by pediatric cardiology. So absolutely, in the I guess, very rare experience where a patient did not discharge from hospital with MISCI in the absence of cardiology follow-up, they need that. They will require follow-up echoes. They will follow up, in some cases, Holter monitors if they had dysrhythmias. They will require a very informed decision in combination with the patient, the parents, pediatric cardiology, and us for any return to sports. And I would suggest to you that it would be dangerous to return to sports even within 3 months after discharge from hospital if they had myocarditis or any degree of cardiac dysfunction while hospitalized. So, the MISCI patients are increasing. It makes sense, quite honestly, because as Arizona now comes down from its 3rd surge in January, many of our pediatric patients, symptomatically or non-symptomatically, developed COVID-19 in January, and they are now 4 weeks out or more and developing the post-infectious autoimmune process, which we know as MISCI. So be aware. The patient's coming to you with more than a couple days of fever and sometimes not any other symptoms, or they have malaise, they have gastrointestinal disorders. Our last 3 patients all presented with apparent gastroenteritis symptoms and or suspected appendicitis. Be aware for those patients. Certainly, those patients presenting with fever and GI symptoms have a 98 to 100% chance of having cardiac involvement as well. So those are kids who earlier rather than later require evaluation by laboratory testing, assessment potentially with echocardiogram. Our dear pediatric cardiology friends and colleagues have been and will continue to be quite busy, and I would suggest that so too those of us in infectious diseases, rheumatology, immunology, who have been seeing, diagnosing, and managing these patients. So it's out there. It's significant. So this is a pretty robust podcast, folks. There's a lot going on. We are certainly not through the jungle yet. My hope is that our numbers indeed are improving and that we will be freed up somewhat to deal with the secondary and softer pandemic of mental health disorders, deconditioning, chronic fatigue, and students who are suffering in the absence of social contact. Those things are not going to change anytime soon, obviously. So we have a long ways to go to try and address those. Meanwhile, all of our own personal efforts to support vaccine outreach, vaccine delivery, and when we get the green light, and I hope it is sooner rather than later, our attempts to support recruitment of pediatric patients into the vaccine trials needs to be robust. It is only in this way that we can hopefully take our entire country and certainly our state back into something resembling a state of health and to try and get a handle on this pandemic. So thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. In the meantime, as I say before, hang in there, stay safe, stay sane, stay passionate, all those things. Thanks, everybody.